acute as well as chronic renal injury is very, very common, both in aortoiliac endovascular procedures as well as procedures for peripheral arterial disease. It is independently associated with both mortality as well as morbidity. It impacts on quality of life, and it is associated with healthcare, with higher healthcare costs. So we need to do something to prevent it. Now, because this is a complex problem, as we have shown, we need a complex, I'm afraid, solution for that problem. And I hope that the vascular community will work together, and that's very important because we need to deliver large cost and clinical effectiveness trials in this area. Acute kidney injury requires treatment, and these patients spend a number of days in hospital having a number of treatments after the AKI has happened. Therefore, there's a great impact on the healthcare systems as well. These patients might require dialysis. As I said, they will spend a number of days requiring intravenous fluids or various other treatments, and all of that is very costly. So there's a great impact both to the patient in terms of mortality and morbidity, and there is a great impact on the healthcare systems themselves. The literature, especially the first few years in endovascular surgery, I would say wasn't fantastic. There have been problems with definitions, so lots of groups have not really been using the right definitions, and it is very common that people don't really use urine outputs or they actually lose quite a few patients in terms of measuring the right markers of kidney injury in the first few days. So there have been a number of issues with regards to defining AKI. I think that we now do have the right tools to define AKI. In the last 3 or 4 years, we've actually produced quite a lot of high quality multi-center prospective evidence on this. So we do know a lot about the incidence as well as quite a bit about the pathophysiology of it. The pathophysiology of AKI is very complex. Contrast does have a role to play, but our literature actually shows that in modern EVA we don't really use that much contrast anyway, and therefore the volume of contrast that we use is not really associated with AKI incidence. So there are many other issues, and especially our patients' comorbidities, that play a major role. Therefore, complex pathophysiology cannot be addressed with something like a magic pill. I'm therefore convinced that we need complex interventions in order to prevent AKI. And in order to do that, we need to be able to deliver complex randomized controlled trials. So I hope that in the future we will be able to fund those big multi-center complex intervention RCTs in this area. I'm afraid it's not an easy task because of how complex the underlying problems are, but I hope that within the next 5 to 10 years we'll get there.